Thank you very much for staying with us in the final hour of the journal with myself, Mmatsheko, Mosito, with you until 12 midday. So last week, global health experts from the DRC, the World Health Organization, as well as Africa CDC met to discuss the ongoing Ebola outbreak in the Democratic Republic of Congo. And the outbreak is, as we understand it, of course, caused by the Bundibugyo strain, and it has spread across parts of eastern DRC into neighboring Uganda, raising concerns about regional and global health security at this time. Let's have a conversation and an understanding with Prof. Salim Abdool Karim, who is joining me on the line. And we're going to unpack why this outbreak is drawing international attention at this time and the key challenges that are facing, containment and the response efforts that are being done at the moment. Prof. Karim, thank you very much for joining me this morning.
It's a great pleasure to be with you. Good morning to you and all of the listeners across the globe, and particularly in Africa.
Absolutely. Thank you very much. We've obviously been following you for a very long time in your work as a virologist and much of the work that you've done in public health spaces, Prof. But let's talk about the Ebola outbreak, and particularly concerning, the outbreak in the particular eastern part of the DRC and the spread. What can you share with us about what is currently happening there?
Sure. So I just arrived back from the DRC in the weekend, and I spent a few days in really the epicenter of this current Ebola epidemic in the Ituri province, which is on the eastern side of the DRC. Most of my time was in Bunia, which is the big city in Ituri province. And I visited some hospitals there, and I visited some Ebola treatment centers and the local laboratory as well. The situation as it stands now, there's close to 700 confirmed cases that have been reported, just around 170 odd deaths, which at this stage of the epidemic is quite a high number, given that this virus has probably been spreading in that region for somewhere in the region of around 2 to 3 months right now. And the numbers are increasing. And what was really difficult to deal with and to see, quite heart-wrenching in fact, was when I went to the hospitals. For example, I went to Rampara Hospital, which is a district hospital in Bunia. They had 18 Ebola patients there. And I went to the Ebola wards and had a chance to chat to one or two of the patients. And what was really difficult was that, they've been dealing with isolation. They've been put in isolation because of the risks of spreading the virus. And that of the 18 patients there, 5 of them are medical personnel. 2 doctors and 1 anesthetist are all in isolation there. And it just highlighted for me the risks that healthcare personnel deal with in Ebola. That patients come in, the risk that these patients pose to healthcare workers, because this virus, remember, is not spread like COVID. It's not through coughing and sneezing and so on. You get it because you deal with the patient's blood and saliva and all of their secretions. And that's what doctors are doing, nurses are doing. And so they're the ones, they carry quite a high burden of the infection in the DRC.
Right. Very concerning what is happening, and the risk that this poses to healthcare workers as well is another layer of this conversation. But perhaps you can give us an understanding. I did mention in my introduction the Bundibugyo strain. Please help us understand, what that is, and perhaps if it poses a different challenge for healthcare workers and public health officials at this time.
Sure. So the initial outbreak, the first recorded outbreak of Ebola, occurred in a small village in the Congo at the time, and that was in the 1950s. And then there was an outbreak in 1976, and this outbreak led to several people dying, and nurses from a local monastery, not monastery, a local church group, were also involved, and there were lots of deaths. And what happened was a friend of mine, Dr. Jean-Jacques Muyembe, was the doctor there at the time, and he saw these patients, and he collected samples, and he sent them off to Belgium, where a good friend of mine, Professor Peter Piot, isolated the first virus that caused Ebola. So the Ebola virus was actually isolated in Belgium from these patients in the DRC, and it became known as Ebola because this little village was near the Ebola River. So it's named after the river. That's where the name Ebola comes from. And we now know that there are at least 4 strains of the Ebola virus. The one that occurs mostly, and most of the previous epidemics we have seen, like the one in 2014 and the one in 2018, were both caused by the same strain. It's called a Zairian strain. This is when the DRC was known as Zaire, and it got the Zairian name. It's called the Zairian strain. That's the one we know well. There are treatments for it. There are vaccines for it. There's a diagnostic for it. So it's a virus we know quite well. It's caused a pandemic in 2014. And that's the virus we're familiar with. But there are 3 other strains, 2 of which we hardly ever see. One is called Thai forest, and the other one is called Sudan strain. We've seen small outbreaks with those. But Bundibugyo is a strain that led to 2 small outbreaks previously. But because they were small and they petered out quite quickly, it's never received much attention. And what we have seen now in this particular outbreak with Bundibugyo is that we know that this Bundibugyo virus has a different structure to the Zairian strain, even though they both cause Ebola disease and called Ebola, but the viruses that cause them are quite different. In fact, that was the big delay. So when the first patients got seen with Ebola, hemorrhagic fever, they were seen clinically and the doctors were diagnosing Ebola. But when the bloods went to the laboratory, the test that they use doesn't pick up Ebola of this particular Bundibugyo strain. It only picks up Zaire strain. So the test kept coming back negative, and the doctors were stunned. What's going on here? It looks like Ebola, but the tests are all coming back negative. So it wasn't until the 11th of May. So the first recorded patient was a nurse from Mongwalo Hospital. And when she came down with hemorrhagic fever, and that's when the first bloods were taken and the first samples were taken. But eventually, it was only on the 11th of May that they decided to send a whole lot of samples to the main laboratory in Kinshasa, because all the local laboratory tests were coming back negative.
Right.
And when it went to Kinshasa, that's when they picked up. They did a different test. And that's when they picked up that this is Bundibugyo strain. And so that's how we know about this outbreak. Now, this nurse was reported with hemorrhagic fever on the 24th of April. She obviously is not the first case. The first case probably occurred about a month or a few weeks before. And that patient got sick, came to hospital. This nurse was caring for that patient, and that's how this nurse got infected. That first patient probably got infected from a bat, because fruit bats carry this Bundibugyo strain of Ebola virus. So it probably came from a bat, a fruit bat, went into somebody who was either in a cave or interacted with a fruit bat, got sick, went to a hospital in Mongwalo Hospital, infected the nurse, and then from there it just started spreading. And today we've seen, so when you work backwards, the first infection probably occurred sometime in late March or middle of March. From middle of March to now, that's what we're dealing with in this epidemic. Now, we don't have any treatments for Bundibugyo. We have no effective treatment. We have no effective vaccine. The vaccines against Zairian strain probably don't work against this particular strain.
Yeah.
And we don't really have an easy diagnostic either. We have a very complicated diagnostic we have to do in quite a big laboratory. So that's been a big problem because it means we actually don't know who's a case and who's not a case. And we have to send a sample off to the laboratory, and then it takes a few days to get the results back. So your problem is that you've got a whole lot of people who are suspected cases, and you don't know whether they've got Ebola or not. So you have to put them into individual isolation. But you don't have so many isolation wards. What you're going to do, you don't have a place to isolate these patients. So it's quite a big issue to grapple with in that kind of situation.
I want us to take all this information because the problems are many based on this Bundibugyo, strain, as you noted, and it's causing quite a lot of havoc. And I want to get a sense of what is happening on a regional containment effort perspective. We continue our conversation with a public health expert, Professor Salim Abdool Karim, when we return.
Rise and shine with Peter Ndoro and Tsepiso Makwetla.
300 Ghanaian nationals that were living in South Africa set to be repatriated. This follows a wave of protests against undocumented immigrants in South Africa.
The continent is supposed to be united for a common purpose. We are supposed to be united as, why are you not doing this to the whites who have been in your country? Are you moving around checking their documents? Are you just saying that it's only Ghanaians, only Nigerians, only Somalians, only Africans, blacks who are living in South Africa without the right documentation? Is that what you're trying to prove? No.
Frit de Hoo, spokesperson for the Ghana Foreign Affairs Ministry.
Big continent, bigger conversations. Rise and shine with Peter Ndoro and Tsepiso Makwetla. 6 till 9 a.m. on Channel Africa, the African perspective. Every headline has a human side. The Journal with Mosito on the African perspective.
23 minutes into 11 a.m. in Central African time in the Health Brief half hour with Professor Salim Abdool Karim. And we're really looking at the Ebola outbreak, what is happening in the DRC, but also the subsequent spread to other parts of the African region. Prof, I want us to look at what transpired last week with the Global Health meeting from the DRC, WHO, as well as Africa's CDC. What was addressed there in terms of the regional containment efforts across the borders?
Yeah, Mmatsheko, I think, we've dealt with epidemics of Ebola before. And in fact, the DRC, this is their 17th Ebola epidemic. So they're not strangers to this problem. They've dealt with it many times before. And the doctors there are pretty good. In fact, if you have Ebola, you want to be treated by those doctors. They have a lot of experience. They know what they're doing. I was very impressed, very impressed. So if you're going to run a response to a virus like Bundibugyo, you need to have quite a holistic approach because you have to involve the community because you need the patients as soon as they become symptomatic to come into a healthcare center, and that within the healthcare center, they need to present quite quickly so that they don't infect anyone else in the community. And in the healthcare center, they need to be diagnosed quickly. As soon as they're diagnosed, they need to be isolated so they don't infect others. And the hospitals have to have all the protective equipment. And then we need to trace their contacts to see and monitor their contacts to see if any of them get sick so that they can come into hospital. With good care, the survival rate is quite reasonable. It's not, Bundibugyo is not as bad as Zairian strain. Zairian strain, 50, 60% of the patients die. With Bundibugyo, the death rate is about half that. But, we don't know exactly what the case fatality rate is at this time. It's too early to tell. Now, all of this requires a response. It needs a response at a community level, it needs a response at a healthcare level, it needs infrastructure, it needs PPE. all it needs huge amounts of money. It needs a lot of logistics. All of that need to be managed. And so and there are many organizations that are involved in this response. When I was there, I was so impressed. And all of this has to be coordinated. So it's coordinated under one umbrella because there's one response. You can't have different groups going around doing their own thing. You can't, that doesn't work. It has to be one response. And so that response is under the joint leadership of the World Health Organization and the Africa CDC. They co-chair this thing called the IMT, the Incident Management Team, in which all of the groups involved report. And so everybody says what they are doing, and that's coordinated to make sure that they're not duplicating and that there are no big gaps and so on. So, for example, I learned a whole new language and vocabulary when I was in the DRC last week, something called SDB. I said, now what is SDB? Well, it turns out SDB is a big problem there. And there are two organizations, the Red Cross and FHI 360, a big NGO from the US, that have joined hands in doing SDB. SDB stands for Safe and Dignified Burial. Because big problem is that when a patient with Ebola dies, they are highly infectious. That body is highly infectious. And so when people at a funeral start touching the body, they are now running a high risk of getting infected themselves. And there's a tradition there that when somebody dies, that the body is washed and people, family members get involved in touching the body. And that's a big problem. So the hospitals, when somebody dies in a hospital, it's not such a big issue because they wrap the body in plastic and they give the plastic, the body wrapped and sealed in plastic to the family to bury. But when somebody dies in the community, that's a separate issue. So these organizations have a whole lot of people in the communities just monitoring for deaths. As soon as somebody dies, they go and they help that family to make sure that there's a safe and dignified burial.
Right.
But we've got a big problem right now because the communities are objecting to the plastic and they want a plastic because the plastic is all black. That's how it's traditionally made. These body bags, plastic body bags are all black. They want to be able to see the face of the body.
Okay.
And we don't have a system for that. So we're looking for now bare body bags with these transparent faces. So anyway, all of this needs to be coordinated and these organizations are doing that.
Absolutely. Prof, we've got 30 seconds and I've got to squeeze in this question. I think it's important because we've seen with natural disasters that nobody is immune to anything. Should Southern Africans be concerned? We've got people listening in South Africa, in Zambia, some in other parts of East Africa, for example, Malawi. Should we be concerned about this outbreak coming to the south of the continent? And are there any systems right now to mitigate that? Just in a few seconds, please.
Yes, this is regarded as a public health emergency of international concern. That means all countries in the world need to be concerned and prepared to deal with imported cases. And we might get imported cases. Fortunately, it's quite easy to control it, or relatively easy to control it. So I don't anticipate we will see any epidemic in South Africa, but we are likely to see a few cases that are imported from the DRC.
Okay. Prof. Salim Abdool Karim, thank you very much. Thank you very much for your insights. A public health expert, virologist, epidemiologist joining us on the line. We really gave us such an integrated look at what is happening with the Ebola outbreak that started in the DRC, but it looks like it is spreading to other parts of the continent. And of course, this conversation all on the back of a meeting, a very important global health meeting of experts from the DRC, from the World Health Organization and Africa CDC. It is 11:30. Let's check in with the latest in sports with Figilele Ngwati.